Okay, so welcome everybody to this CPC seminar, and I'm delighted that Mariana Sousa Leite is able to join us. Mariana is from the School of Psychology at Cardiff. She has research interests in various aspects of infertility and parenthood decision-making. So Mariana did her PhD at Cardiff and was awarded it in June 2024. And she's been busily writing up papers from her PhD and other projects, and has an impressive array of publications in journals like Human Reproduction and Reproductive Biomedicine and Infertility. So after the PhD, she won one of those ESRC postdoctoral fellowships for a year to continue to write papers and also to write a research grant for a fellowship. So that's what she's been doing, and she's been visiting CPC to see how demographers look at reproductive decision-making and to see whether there are some differences and synergies and how the two approaches might be combined. But today you're going to talk about your PhD. So Mariana, we do have to leave the room at about 1:50, 1:55. So without further ado, I'll let you get going.
So thank you, and hello everyone. Thank you for this invitation to speak today. It is a very great pleasure to do it. So I hope you find this presentation helpful, and I hope that in the end we can combine our backgrounds and insights into a very fruitful discussion. So I will start by presenting my research vision. So with my work, I aim to support people in the 21st century achieving their desired or intended parenthood goals and helping them adjust when attempts to achieving these goals are not successful. So I do this, and I've been doing this by developing and evaluating support resources to support those who desire to have children, but also the involved stakeholders. So my ultimate goal is that this support can be integrated into routine clinical care and easily accessible by these stakeholders. So the objectives for this presentation, I will start by a brief overview of the declines in fertility rates and the infertility prevalence and treatment. And I will focus my presentation in fertility treatment, which is where I have expertise in. I will speak about the demand for evidence-based fertility end of treatment care, and I will introduce this topic and the importance of doing this during and after treatment. And then I will end with a discussion of implications for practice and research. And I will do just a brief preview of the psychosocial demographic approach that Anne was just speaking about, that we are start thinking and that I would like us to think together. So as we are all aware, fertility rates are decreasing dramatically for many countries, and estimations indicate that by 2100, almost all countries will have total fertility rates below replacement levels. So this demographic change have profound implications economically, socially, geopolitically. And there are research shows that are various reasons why this is happening. For example, postponing parenthood due, for example, women's participation in the labor market, because of the economic uncertainty, also changes in parenthood desires and intentions, gender equity, and also infertility, which in some way it is related with other factors. So it's a cause and consequence of other factors. So my research has focused on infertility and how supporting people in achieving their parenthood goals. So infertility prevalence, and here we have lifetime prevalence. So if you have been confronted with infertility in any time in your life, and also period prevalence. And being more cautiously, we can see that the average prevalence of infertility is around, or worldwide, is around 13%. And this, of course, varies across more and less developed countries. It is important to note that these might be increasing due to the increased risk of infertility, and those also who are increasingly using ART due to social reasons or social barriers to reproduction, for example, same-sex couples and single women. So among those who are infertile, we know that at least half seek medical help. Despite the advance in fertility treatment, we know that many patients end these treatments without achieving a live birth. And when I'm referring to patients, I'm referring to those who have infertility. And in these concepts, I'm including everyone who cannot have children spontaneously. So it can be due to medical problems, but also social reasons, as I said. So I did this graph in a different way. So I did not put that. I think you are used to see the percentage of people that achieve a live birth, but I did this graph in an opposite way. So that's why the proportion is decreasing. So the proportion of patients who went, like, as the number of cycles attempts increased, the percentage decrease of facing an unsuccessful cycle. So this is a cumulative percentage. So it would be increasing if we were considering the percentage of ending treatment with a live birth, and in the case it's decreasing. But as you can observe, most patients, we know that in the UK around 95% undergo up to 3 cycles. So if we look to the graph, even the most optimistic estimation show that at least 4 in every 10 patients will end treatment without a live birth. So we know that these can have a very high impact on patients. So it tends to trigger intense and enduring grief associated with negative feelings of loss, emptiness, isolation. And metasynthesis research shows it is associated with impaired well-being and mental health. So despite the likelihood of patients who are undergoing treatment facing an unsuccessful treatment, so ending all treatment cycles without a live birth, the psychosocial burden that this outcome triggers on patients, and the national infertility guidelines and regulators call for the need for evidence-based interventions and support for these patients, there is a lack of evidence-based support and recommendations to this end. So, and this is what informs my research. And my question is, how can we support and improve family building opportunities for this underserved group of infertile patients? And I advocate, or I think that there are 3 ways of doing this. We could target patients before treatment in a preventive way. For example, with family building awareness and planning at optimal reproductive ages, or we could target patients during treatment, helping them contemplate alternative family building options and alternative value life goals beyond and towards parenthood while still undergoing treatment, or we could target patients and supporting patients coping with unsuccessful adult treatment and contemplate alternative value family building options, if possible, and life goals beyond parenthood. And this would not be an optimal time, and I will show why. But during my PhD, I focus on these 2 approaches. So thinking about during treatment, I don't know if you are aware, but on average, from time to diagnosis to time to pregnancy, patients can undergo treatment on average for 7 years. So if we think we could promote the contemplation of alternative family building options during this period, it seems that research shows that patients tend to focus on alternative family building options when they exhausted their treatment options, and this could be linked or associated with some historically because in previous years people would be discouraged to undergo to pursue alternative options, for example, adoption, especially in the UK, while still undergoing treatment. So it could be, in a way, related with this historical reason, but they tend to only focus on alternative life goals family planning options after treatment. And we know that the UK women patient average age undergoing treatment is 36. So we can see that these alternative options are not being optimized. So this research, and considering this approach of during treatment, this research initiated a paradigm shift in the role in psychosocial care provided in fertility treatment on how we plan for treatment. So usually even research and also clinical care tend to focus only on successful end of treatment, which is defined as achieving a pregnancy or life birth, or have been defined until now. And speaking about an unsuccessful end of treatment tend to be avoided in fertility care. So, but psychosocial research and even other empirical research in other related fields, for example, cancer treatment or other health fields, show that it is beneficial for patients to prepare in advance to possible negative health outcomes. So in this in mind, we conducted a bilingual mixed methods online survey with patients and asked them if they would be willing to be counseled in advance about the possibility of treatment being unsuccessful. And results showed that almost all patients, 93% patients, would be willing to have these conversations while undergoing treatments, and even most of them before initiating the first cycle. But only 35% is receiving this opportunity, and qualitative analysis showed that even they have this possibility is not targeting, and it's not being delivered in depth, in sufficient depth as they would desire to, or they perceive they would desire. So we conducted multi-countries focus groups in Europe and Latin America with patients, patient advocates, and healthcare professionals about this end of treatment care. So to prepare and inform patients for the possibility of unsuccessful treatment and alternative options during treatment. And results, and this was done by using a qualitative analysis, and results showed that all stakeholders agree that doing and providing this care routinely is needed and beneficial. However, they perceived benefits and barriers, both, although patients tended to perceive more benefits and healthcare professionals tended to perceive more barriers towards this care. For example, better cope with the treatment, and it would enable to make more informed and timely decisions about treatment and parenthood. It would help managing expectations, but on the other hand, would trigger emotional distress, would hinder patients' optimism and engagement with treatment, and healthcare professionals perceived, and also patients, that there is a lack of know-how and resources on how to do this, because this is something very difficult to talk about. Patients are undergoing treatment, they want to have a child, and we are talking about the possibility of this not happening. So this is a very difficult thing, even for healthcare professionals to deliver. And so we have some quotes here. For example, a patient: if I would have been braced for the reality, I would have done things differently. The reason why many clinics don't have that conversation early enough is because they don't have anything really to offer. So we partner, so these benefits and barriers, just to mention that this seems to mirror the trajectory akin to psychosocial care in other healthcare domains that I just mentioned. And this care now proved to be beneficial in these other health fields, integrated into evidence-based best practice recommendations, and considered an ethical clinical duty. So we partner with some associations, fertility professional and patient charities associations, scientific and professional associations, and this was also in this study that I just mentioned, the focus group, the multi-country focus groups, and we developed research-informed digital educational resources co-developed with these stakeholders' involvement to promote the end of treatment care during treatment as routine practice at fertility clinics. So I had a video here that I would love to show to you, but it is not working. So I needed to take out the slides, but it is the video of these two web pages that you have here, the web link and the QR code. And these are web pages to inform how to help healthcare professionals deliver this care, and also to patients to help them on their own pace contemplate this possibility and look into alternative options and read about what most patients experience during treatment when it is unsuccessfully. So these are now freely available online in 4 languages via these websites. So this is the support that is developed so far, to my knowledge. And then we have our third approach that I just mentioned to you, which is supporting patients after treatment. So to my knowledge, there are only 2 interventions to support patients at this stage. These are the reference to this. So one of them is directed to support women with reported depressive symptomatology after treatment, and the other one is a self-help app to help anyone who have an unmet desire for children. So these interventions showed good acceptability and feasibility and promising efficacy in promoting users' adjustment, so translated into mental health or well-being, but they were not evaluated in specific population of fertility patients. They are a self-help program, so sustained adherence is mixed. And also there is no buffer effect in supporting patients in the transition to the end of treatment. So, and it was in response to this need and to address this need that we developed Beyond Fertility. So Beyond Fertility, Beyond Fertility is a brief face-to-face psychosocial intervention, to my knowledge, the first brief face-to-face interventions to this end, to promote patients' healthy adjustment to the end of unsuccessful fertility treatment. So I'm not going into detail about this intervention because I don't think this is the point of this presentation. I will just go briefly about what this intervention is and what we have developed so far. But I'm not going into detail about the psychosocial part of this. So we have this intervention, the novelty beyond being face-to-face, it's that it encompasses the 2 approaches that I just mentioned to you. So supporting patients during treatment and supporting patients after treatment. So we have a 1-to-1, 1-session, individual couple session to inform and prepare patients for the possibility of facing the end of unsuccessful treatment. And this happens within 1 month before they initiate their final cycle. And the other session, we have 6 sessions, 1 in individual couple format and 5 group sessions in group with other patients who also ends the end of unsuccessful treatment. So this is during treatment, and this is directed only to those who face this outcome. So the goal of this intervention is to promote patients' healthy adjustment to this outcome, which is translated in better quality of life, which is aimed to be translated into better quality of life, well-being, and mental health. This intervention was developed following evidence-based frameworks on how to develop and evaluate complex interventions, and also in psychosocial theories and therapeutic models. So, of course, we had a logic model, and this encompassed, it was a very long period of work, but I will just present you the results. So we conducted feasibility testing, and here are some quotes from patients about those who engaged with Beyond Fertility about this intervention. I want to say that this study showed feasibility implementation constraints that needed to be addressed before proceeding with an efficacy testing. So, but what this pilot study showed that it supports these psychosocial mechanisms that theory about on how people adjust to block parenthood goals, how people adjust to these unsuccessful end of treatment. So, for example, helping patients accept their inability to achieve parenthood or have more children with treatment, helping them increasing their perceived social and relational support, help them construct positive meanings about their efforts to have children, and also to find valued life goals, alternative valued life goals, and finally helping them pursue new life goals, and these can be alternative family building options or even a child-free lifestyle, and focus on alternative life goals that go beyond parenthood. And here are some quotes from patients, made us think we are not different, that the fears and anxieties we feel are common, show us through the dynamics, so the activities we did in sessions, there is a whole world beyond the pain. And then we proceeded with an efficacy testing via a multi-center randomized controlled trial. And I will end my presentation. This is the last study I will show to you. So as you can observe, this is just like briefly the main results. We tested the efficacy of the session during treatment, so that in a way that second approach I just mentioned to you in the beginning. And it showed that the 2 weeks after the end of the cycle, of this last cycle, there was a difference of 4 points between those who received no intervention, so the usual care at clinics, and those who received Beyond Fertility. So this is the equality line, and the points that are above this line show that patients reported better quality of life at time 2 than at time 1. So this is the quality of line, which means that the values in this line would be that they had the same quality of life at time 1 and time 2. If it is above, at time 2, they would be better than at time 1. And if it is below, they would have better scores of quality of life at time 1 than at time 2. And as you can observe, we have more blue points above the line. When we tested the full Beyond Fertility sessions, we can observe a difference of 8 points between these two groups in the same direction. This was 6 months after Beyond Fertility. So this was the first empirical evidence of this type of care and care after the end of unsuccessful treatment. And there were some constraints here. For example, you see a lot of points here and just some points here, because, for example, most patients, although they thought that it would be their last treatment cycle, a lot of things happened. For example, they went to the private sector, or they the cycle was cancelled and they had a new one. So most patients did not end treatment when they had a negative or adverse cycle outcome, which is very interesting. But that's why, so we had the number of patients in this RCT in the end was very low, so we did not have sufficient power to detect small differences, and if you can observe, the difference did not reach statistical significance. So this is the first the first empirical evidence, I will say, but we need much more tests, and I hope these results were very interesting in terms of type, mode of delivered, content of such support that can inform future and also the modifications to Beyond Fertility of support sources. So I will end my presentation with some discussion points. And I think what this work showed was that support during treatment may be beneficial. So we need to explore more this preparation and information during treatment. It also clearly showed, and even I did not go into detail and in-depth about the qualitative analysis, but it clearly showed that the end of treatment, it is not the end of psychosocial care. And that this, although patients stop treatment at the clinic, medical treatment, this does not mean that they need to end the psychosocial care at clinics. And it seems that promoting acceptance and alternative routes to parents or life goals beyond parenting seems to be the mechanisms that promote a better adjustment for patients. This is some questions that provocative questions that I would leave you to, which is, should we shift or reconsider the narrative about what constitutes a successful end of treatment? And these already stimulated debate in the literature, and the just ethical paper just came out about this as well. What should we consider a successful end of treatment, just achieving a live birth, or is it achieving a parenthood goals? What it is important is that patients achieve their desired parenthood goals, irrespective of what that is, or beyond achieving or not parenthood is a healthy post-treatment adjustment, is that they healthily adjust after treatment. For example, there is a study that showed that sustaining a child wish or not have an impact on well-being beyond the parenthood status, having or not children, but if patients desire to have, still desire to have children. So this is some questions that I leave it to you to think about. But of course, we need much more volume of high quality research on end of treatment care and powered RCTs with a high number of patients. So this is where I would like to move now my research on how can we support and improve family building opportunities for this underserved group of infertility patients, but focus here more in before treatment. So should this be promoting awareness and education about family building options at an optimal reproductive time? Should we support people planning their reproductive plans at a medical age, that they would be at an optimal medical time to achieve these goals? And so I think there is kind of tension on how to address these in terms of a medical approach, which is just what I just said, and also in a demographic approach that would say, which is a social approach that would see, would it be knowing that, considering that people do not achieve their parenthood goals due to, or want to focus, or we need to consider their social context. For example, want to focus on career, do not have a partner, do not have financial security, among many other reasons. And also keeping in mind that we need to do this with reproductive autonomy, justice, and rights. So how can we combine this, the medical optimal time, with the social context of people, also keeping in mind that they need to have this when they desire, how they desire, if they desire it. So this is, in a way, some brainstorming we have been discussing. This was something that was, and this slide, something that was discussing in the conference in 2024 in Vienna. So I end this presentation with some questions that I think, and areas that I think need more work, and we could, I would love to hear your insight as well. So how can we best support people prior to infertility treatment? So I think I decided to focus on new family forms. So should we first understand how these new forms of families that are seeking our assisted reproductive technology, fertility treatment, are eligible to seek fertility treatments in the current context of the decline in fertility rates. So we know that same-sex couples, single women, even polyparenthood. So there are new family forms that are emerging, and in the way to support them in a correctly way, I would say we need to understand who are they, what are their characteristics, what are their needs. Also understanding how their fertility desires and intentions evolve for these new forms of families, so that we can inform governments to adjust their policy setting appropriately. So when, how, how can we do this? I will end my presentation here. Thank you. I would like to thank my mentors and also other research collaborators in this work. Thank you.